NorCal SEPA welcomes you to our Membership Community Workshop Series, highlighting local leaders and expanding the impact of somatic experiencing in the Northern California region.
Welcome, and thanks for joining us today for our second of our webinar series for the Somatic Experiencing Professional Association, better known as SEPA. And I'm here, Maureen Harrington, with your other board members, Mike Shangaris, Andrea Gage, and Gwen Gilson. Our esteemed speaker today is Mark Ludwig, and we're really excited to hear what he has to share, and hope you can hang out and listen and take in, and are we going to have questions afterwards?
I think we have a half hour at the end.
Yeah, so we'll have time for question and answer for the last half hour of our day at 1 o'clock. So I will pass it to you, Mark. Thank you.
So I would like to introduce Mark. Mark Ludwig is a previous professor at CIIS. He's been a leader in the field of somatics for more than 2 decades. He's been in leadership of USABP, helped run and establish the USABP conference for many, many years. He's somebody who cares deeply and passionately about the ways that trauma treatment happens, the neurobiology of change, and the way that the body and the mind interrelate, particularly looking at moving the field from fiefdom to collaboration. And this talk will be working on how do we understand SE within a family of other trauma treatment models. We are very lucky to have Mark Ludwig's expertise and skill with us today. And so without any further ado, I'm going to pass over to Mark.
Yeah, good afternoon, everybody. Thanks for showing up for this presentation. I'm not sure, I can't see any of you because I'm on a presenter's screen here. Can people see me? Does everybody see each other out there?
Absolutely.
Michael, okay. So I'll try to manage my face even though I don't see anybody. I'm in practice, I'm a social worker in practice in Oakland, California. I'm on the ancestral lands of the Chenyo-speaking Ohlone people who have inhabited Oakland and the East Bay for thousands of years. I pay land tax to that community for the privilege of being on the land. And I'm currently presenting today from the ancestral lands of the Piriku people along the shores of the Gulf of California. I want to also, before I start, recognize the massive fear and suffering taking place in the Middle East right now. My interest today is the professional education. I believe that body-based clinical practices need to understand the psychology field at large in order to find our place and realize our potential both in trauma and in other psychotherapeutic interventions that we make. I'm not an expert on cross-modality trauma. I'm a curious observer of healing paradigms. Many of you have probably have more experience in implementation than I do. And I look forward to hearing from you in our discussion period. My overarching understanding or my guess is that all trauma therapies and all psychotherapies have a regulation intention at the base. I think that's one of the unifying principles of cross-modality looks. So it depends on what systems and subsystems are being re-regulated and from what direction, top down or bottom up. So let's keep our minds open as we look at the existing trauma models and let's see what regulation channels each modality is developing, and we can talk about that later. So I go to slide 2. A broad distinction is made between therapies that have with different targets. Some target event processing or memory consolidation, some target symptoms, some build resources around the traumatic events, some mobilize human support. We'll be looking at models that have various targets today. This researcher Lewis here that I'm quoting, I think has the similar idea. He's looking to see what, looking at all trauma models, he compares something like 25 different RCTs, research protocols, and looks for what is the most effective, the uniquely effective ingredients in each model. Yeah. Slide 3, please, Michael. This is the models we'll be comparing today. Our near and dear somatic experiencing, psychopharmacological models, critical incident debriefing, kind of the grandfather of all trauma models, cognitive and cognitive behavioral therapies, the neurosequential model, Bruce Perry and his team, and EMDR, and a little tip of the hat to psychoanalytic ideas and the surging popularity of psychedelic therapies. So next slide. I'm going to try to attempt to not read the slides, but to leave them up for enough time for people to read them. The important part of this slide is that the core symptoms of PTSD need to be kept in mind as we look at these models to see where each model is directing itself towards intrusion, avoidance, alterations in cognition and mood, or marked alterations in arousal. Of course, the important point for the DSM is that it has to be a significant distress and impairment of social occupational functioning. So we won't bring up the whole PDS model here. Next slide, please, Michael. Brief overview, somatic experiencing. The strength of the SE model, in my opinion, is its whole person approach. We try to meet the embodied person at multiple systemic levels and various temporal spheres. I think there's an inherent recognition of the limits of human adaptation and the kind of complications that reaching those limits brings into each embodied life. I think SC is faithful. Peter's background gives him insight, I think, into the phylogenetic organization of our organism, and also increasingly on the human development across the lifespan issues. And of course, the experiential existential level, I believe we are shining in our expression of our humanity, in our approach. Next slide, somatic experiencing 2. SE theory is influenced by change concepts arising from the study of dynamic living systems. This is my opinion. Dynamic living systems are never at rest, constantly working to maintain our homeostasis in its multiple and interconnected subsystems. I think all of these therapy models, especially SE, are looking for balance. Unfortunately, balance is often achieved by the adoption of the best available regulatory strategies, many of which are often suboptimal. Change requires gradual undoing of non-optimal constructs. Resistance to change arises from the discomfort and anxiety of this challenging reorganization. Find my cursor, I'll change. Next slide, please. Number 9. This is, I think SE has a model of unfinished body business. The completion of initiated responses helps us to reestablish coherence and agency, reduces feelings of helplessness, restores access to our resources, both internal interpersonal and environmental. We increase tolerance and acceptance of his inner physical sensations and emotions, and through the process of the SE therapy, we activate internal and external resources. We are a model that specifically avoids direct and intense evocation of traumatic memories. Trauma-related memories are approached indirectly and gradually. The next slide, I hope you'll be able to read here. It's slide 10. I think it's a good slide. It's from some of the SE and some of the Institute. I think it's a very nice slide of the kind of the areas of the human nervous system that we're most active in. This core response network. Can you read that on your screen? Anybody? Anybody?
Yes.
Oh, okay,
Yes.
thank you. Initial trauma responses are automatic nervous system reflexes. The responses are activated out of our awareness, often leaving a survivor with a bewildering feeling that something happened to me, but without a coherent understanding of the sequence of events, nor the meaning making, the primal meaning making that took place at the moment of the events. Flowing down to reprocess emerging sensory information and access the core response network are essential features of our approach. Nice, I love that slide. I'm going to make a t-shirt out of that, I think. Let's see here. Next slide. Psychopharmacological interventions. I have to say, not too much to say about this. They're only a common feature of trauma scenarios because people often come into contact with medical professionals first when after events and after symptoms emerge. And the go-to is the psychopharmacology. Psychopharmacological interventions are common first-line responses to early emerging trauma symptoms, symptom treatment model. Event of the traumatic experience and its biopsychological expressions may be misinterpreted by the client and medical personnel. People, as you well know, people don't always know when a trauma has taken place and only feel symptoms afterwards without having an idea of where the symptoms originated. You need professional help to do that. And so people show up in the medical fields looking for relief from symptomology and they get it there. Additionally, effective PTS treatment protocols are not universally available, and symptom treatment is often the best option. So benzodiazepines, anti-anxiety medications are given in 74%, prescribed in 74% of people diagnosed with PTSD. Antipsychotics are considered contraindicated. Next slide is treating nightmares with prazosin is recommended, and I would say it probably would be supportive of more restful sleep. I'm sure that's mediated by the chemical effects of the drug, but it's an essential to have restful sleep in order to support the recovery process, long-term and short-term. So that's a useful drug in that scenario. Next slide. Recently, anti-memory consolidation drugs have emerged. This is, I think, mostly been celebrated in the military uses and battlefield use. Effective use appears to be a matter of careful timing. Medication presently in use must be administered within 6 to 12 hours to reduce. This is the target. Fear-inducing memories is the target for these drugs. And so, interestingly, hydrocortisone has been proven to be the most effective. Those of us who take hydrocortisone for other things should be aware of this, I suppose. But is the administration of hydrocortisone to boost cortisol levels and an interruption of parasympathetic response to shock? Just a question I have is, if you want to introduce more cortisol into the body, what is the impact on the full range of trauma experience? Okay. Next slide, please, number 15. Critical incident debriefing. It's among the first widely organized trauma response approaches. In 1999, I had the honor of accompanying Bessel van der Kolk and other therapists to South Africa to tour trauma response centers and to meet with the Truth and Reconciliation Committee. The critical incident debriefing was the most common training among the 25 therapists on that trip. By the vast majority, really, there was just a handful of somatically oriented people, including Pat Ogden and some of the Europeans. Somatic approaches were just beginning at that time. The USAVP had just been formed, and we were just on our way towards the communication that we've achieved between our own modalities and with other modalities. Next slide, 16. Critical incident debriefing is among the first recognized trauma reduction techniques put into organized use. It is reported, and a lot of these modalities kind of play on this idea, as we reported that lifetime prevalence rates of exposure to trauma in the general population is over 70%. 30.5% of people will be exposed to at least 4 PTEs in a lifetime. There's question in the literature about how many people recover in a so-called natural healing process. Obviously, those who don't recover in a natural healing process are the subject of the clients who come to us and to these other modalities. Let's go on to the next slide. Critical incident. The central motivation of the critical incident research is the optimal maintenance of functionality. It doesn't address the underlying psychobiological mechanism, but it can surface community members who are needing deeper support. This is a little bit of a sketch of the phases: facilitating mutual support for workers, opportunity to identify workers requiring additional clinical support, and other gains, increased levels of social cohesion, reduce harmful responses, reduce levels of sick leave, improve workplace performance. So you can see the industrial use and business imperative here. Let's see. Go to the next slide. The model is based on an introduction where debriefers explain the goals of the debriefing. And then, as in the small group picture here, each participant describes their position during the event. I think is very interesting addition. Thoughts for each participant describes what he or she thought. Reactions or emotional reactions and feelings are explored. And then the fifth phase allows participants to participate in and describe their physical, emotional, and behavioral reactions. And then in psychoed intervention, debriefers provide information for common reactions. And then a summary is made of the input of all the members and the state of the group at the end. Apparently has little effect on psychobiological symptoms in PTSD. Most of the providers are non-clinical members of teams who might have been designated but undertrained in this technique, and thought to be contraindicated for people who are in continuous trauma scenarios, because it may increase the levels of vulnerability and to the level of overwhelm. Okay, next slide, please, Michael. Cognitive models. This is the 100-pound gorilla in the room, or that's not very heavy. 500-pound gorilla. Cognitive and cognitive behavioral interventions are the most researched and most employed trauma treatments. They're endorsed by the Department of Defense and are the treatment of choice for in the health maintenance organization systems, such as it is. Next slide, please. Slide 22. Judith and Aaron Beck developed many of the parameters for this treatment model in the 60s and 70s, starting with the focus on automatic thoughts and depression. Beck was a psychoanalyst. He worked at Austin Riggs, actually, up in Stockbridge, Massachusetts, and the psychiatrist and psychoanalytically trained. Turned in another direction, didn't he? First clinical trials of CBT versus medication were published in 1977. Fundamental to cognitive model is the way in which cognitions, the way we think about things, and the content of thoughts is conceptualized. So there's a breaking down and deconstruction of thought processes, looking at underlying core beliefs, illogical assumptions, and negative automatic thoughts. And the core of that model. Next slide. Core beliefs help us to know what to expect and provide an explanatory matrix that provides some level of psychological coherence, often suboptimal, but we use our core beliefs, perhaps something along the lines of what Bowlby describes as internal working models, how the world works, what we can expect from the world and from people, and how events and phenomena get integrated and life moves on. These are internal working models that are often violated by trauma. Core beliefs, in brief: perceptions create thoughts, thoughts shape perceptions, perceptions and thoughts elicit a motivational, emotional process that creates behavior. Behavior reinforces thoughts and perceptions and the resulting emotions. Therapeutic change is brought about by questioning perceptions, thoughts, emotions, and behaviors from the point of view of rational reality testing. 24, slide 24, a little model from the cognitive model about negative views about the world, negative views about the future, negative views about oneself, create a merry-go-round into a cycle that's very hard to break, as each element reinforces the non-optimal psychological situation. Let's see. Slide 25. Natural extinction is a concept that I think needs more study. It's the failure of natural extinction, which results in the domination of inhibitory processes. Inhibitory processes are dominated by excitatory processes, yin and yang. Excitatory processes, continuous excitatory processes, are expressed in the high levels of adrenal activation and PTSD, excitement nonstop. PTSD has been conceptualized as a disorder that arises in part due to failure of the natural extinction reported by research demonstrating that the vast majority of individuals exposed to traumatic events experience symptoms of PTSD immediately following the trauma, and natural recovery occurs for many over the subsequent weeks and months. Maybe we can bring that into the discussion later, and whether what SC thinks about that idea about how natural extinction develops. Slide 26. Central principle of exposure therapy in PTSD is to confront patients with objects of anxiety in order to allow them to learn new associations that are contradictory to the dysfunctional beliefs instilled in their memory due to traumatic situation. And then the symptoms that are there that continue to develop. Slide 27, exposure therapy is the most common treatment model in trauma CBT or PTSD. Exposure therapy is a general strategy for reducing unrealistic anxiety through confronting anxiety-provoking or avoided thoughts, situations, activities, and people that are not inherently harmful. Exposure therapy involves repeated confrontation with feared stimuli and the absence of the feared outcome, creating new learning, and over time, fear extinction through exposure. Slide 29, prolonged exposure is both inside the office and outside the office in what they call in vivo exposure, as well as imaginal exposure conducted through the direction of the therapist. Prolonged exposure asks the client to be aware in their ongoing life of the triggers in daily life that challenge them physically, mentally, psychologically, and emotionally, and to put into place a variety of mental and respiratory interventions and relaxations that can help them not give in to the trigger and to re-expose themselves to the somatic solutions. There's some really good videos of this exposure therapy in action that you can learn a lot from, and there's some websites there at the bottom. It's a difficult process. Apparently, there's the failure rate and the withdrawal rate is pretty high. One of the initiators of this, FOA, gives this instruction: I will ask you to recall these painful memories as vividly as possible. We call this reliving. I don't want you to tell your story about the assault in the past tense. What I'd like you to do is to describe the assault in the present tense as if it was happening right now and right here. Contributing, I'm sure, to a dropout, especially in extreme cases. Next slide, slide 31. In vivo exposure is the real life stimulation of, for example, in vivo exposure would be the real life experience of, say, for example, dark streets, certain noises, certain silences, and certain touch experiences. As you'll see in the virtual reality prolonged exposure model, the sensory input is that's recalled is pretty vivid. Prolonged exposure therapies have an educational component, and interestingly, training in controlled breathing. Be interesting to see historically when that was added to their model. Subject to and homework, introduction of the SUDS concept, subjective units of distress scale, 1 to 100, 1 to 10. How upsetting is this? How activated do you feel? Is tested throughout periodically and regularly throughout the exposure sessions. At the end of each imaginal exposure session, the therapist spends time discussing their experience. I'm sure that's another way of putting it in a box, in a context behind you as something that took place and now has a closure to it. And then insights that are helpful or resources that are discovered or reinforced in that period. Next slide, 32. Again, several studies that I came across from the CBT model said that there's a general reluctance to employ exposure therapy in PTS cases because of the level of disorganization that clients can bring into the treatment room, and perhaps the inadequacy of the model to manage levels of distress in a more titrated model, although they seem to be taking on that language. Two additional common reasons for therapist reluctance are a preference for individually organized over manualized treatment, and concerns that patients will decompensate. Okay, slide 33. Virtual reality treatment. Special effects. These are also, I'll give you some websites for looking through the lens of a virtual reality helmet. Pretty scary. Virtual reality therapies are technologically enhanced applications of exposure therapy. Virtual reality have been used in the treatment of post-traumatic stress since the 90s, end of the 90s. The use of stimuli directed towards different sensory channels improves the patient's immersion in the virtual environment, and it is hoped will evoke the feelings of being present in that world. Different stimuli are included in the virtual reality therapies: sound, vision, sound volume, color, the environmental, cultural context, and touch. Interestingly, I see that the Department of Defense is employing a model in which the client is holding a replica assault rifle and a virtual reality helmet at the same time to evoke the realness and the immersion into the original scenario. 35. Some virtual reality programs make room for, and prolonged exposure therapies make room for emotional expression as a sign that reprocessing is taking place. Another thing we could talk about later is how does SC look at the accompanying emotional expressions in the trauma recovery process. Okay, not so much is vital there, but there are these virtual reality videos here which are intense. Let's see. Seems like a factor in the development of virtual reality was to create interactive technology which would allow the client to make more virtual choices within the original trauma setting that's being viewed virtually. This is thought to enhance the realness of the VR experience, but also to support the emergence of imaginable possibilities for different outcomes or different choices that were made at the time of the original exposure, the original trauma scenario. And possibly those imaginal and new choices might affect the inevitability factor of PTSD. I'm wondering that. That's my wondering. Slide 36. I trained a neurosequential model of therapeutics through the infant parent mental health program in Napa, conducted by Christy Brandt and Ed Tronick, which I participated in for many years. And one of their offerings was to enter into this training model. If you're not familiar with it, I think you'll find some of the elements make a lot of sense. The neurosequential model is a model of neurosequential interventions that treats the most basic neurological dysregulations, starting with brainstem functions. Slide 37. I need to say that the NMT is a team approach. As you'll see when we look at the intervention levels, it requires specialized training. So there's OTs and PTs and psychiatrists and neuropsychologists and social workers and nurses and all kinds of psychotherapists and educators to carry out this model. But I think it's a pretty optimized model when it's conducted, and it's mostly being used through the Child Trauma Academy that Perry established in Texas. NMT enables a clinician to match a particular therapeutic intervention with the developmental stage of the child. Special emphasis on the brain region and the neural networks mediating the problems in functioning. Quite an interesting model. Next slide, 38. See, give you a minute to read that. It's not an intervention model. It's a lens to guide clinical problem solving. The next slide will give some graphics on an interesting graphic, I think. There's slide 39. This is from the childtrauma.org website. You can see that they are specialized in working from brainstem, considering brainstem dysregulations, and then diencephalonic, and making cortical. And you see here a list of symptoms and the targets of intervention. Just let you look at that for a moment. The developmental approach, let's see if we can put that on the agenda too for discussion. Is SE developmentally informed or more phylogenetically informed? Okay. Clients are evaluated at their entry age into treatment, and they're compared against a lifespan developmental model of typical psychobiosocial cognitive development in order to support the development of a sequential treatment plan targeting the earliest level of needed developmental support. Not necessarily exclusively, but the brainstem issues were involved. In a child case, you would have your treatment plan would include brainstem interventions and might also include starting on the relational difficulties and other levels at the same time. Daily schedules and weekly charts are organized to target underdeveloped neuropsychological capacities. So at the end of during the course of that training, we were gifted many templates for the use of developing these week-long 24/7 models of different kinds of activities and professional interventions that would be needed to support the neurosequential model of healing. Okay, let's see here. These are more details on the brainstem functionality questions. And then slide 41, the diencephalon cerebellum functions, which I think is an important distinction, which really was just introduced to during my training in that model. Brainstem and diencephalon have different functions. And then slide 42, limbic functionality. I'm target for many people with PTSD who do not have earlier deficits in development, often come with a lot of symptomology in this area, relational area. And then the cortex, slide 43. Integration, delayed gratification, sense of self, access to language. And then slide 44, nonverbal intelligence. Modulation of reactivity. Morality. So slide 45 is a model from the neurosequential model that shows that caregivers and partners' capacities are also tracked to guide the treatment of the clinical dyad. Caregivers or relational partners are always included in the co-regulation model. And so a well-regulated parent is responding to hyper aroused and unreachable child, and hear, see, touch, hold, rock as the interventions, brings down the arousal level in the child over time. I think we could use these kind of models ourselves in the SA community. I know one of my trainers, Steve, really liked the hamburger, but I think we can, as a model, but I think we can use some more developed models. Okay, slide 46. EMDR is a research-based trauma model effective in the treatment of PTSD. It's a dual activity model within a frame similar to trauma-based CBT exposure models. So it's a dual activity. They have the retelling of the traumatic experience and the tracking of that retelling, and the contribution of the eye movement and the dual activity, bilateral eye movement, and trauma recall is not fully understood, as far as I can see, in the right up to the present moment. Shapiro speculates that that's an essential feature of the method. I'll get back into that for a moment, but I'll tell you about her speculation. But some writers who are describing the research on EMDR were speculating about whether the dual activity in some way distracts or lessens the impact of the trauma recall, which allows change to take place without with some distancing from the arousal. Distancing, it seems very much to be a part of the EMD model. Okay, slide 47. Every therapy model has an origin story. I think Peter told me the story of falling off his bicycle and failing to wait long enough before he got back up. The origin story of EMDR is while taking a walk in a park, Shapiro experienced a personal revelation that would ultimately lead to the development. He noticed that her own distressing thoughts and emotions seemed to diminish as her eyes moved rapidly back and forth. A good catch, Francine. I think she stayed faithful to this idea that it's a compatible and flexible model that was developed to be compatible to all major orientations of psychotherapy. Many different kinds of therapists use this, including SE therapists and other somatic psychotherapeutic models. Slide 48. Strong evidence for EMDR right from the beginning. Mechanisms of effectiveness remain controversial. Has the strongest recommendation as an effective treatment from the VA and the DoD right up to 2023. Let's see, 49. How does EMDR work? The neurophysiology behind memory and coding and processing and the effects of bilateral stimulation have been researched in this model. Shapiro believes it focuses that the bilateral and dual activity model focuses the similarity between delta waves in slow wave sleep and those registered in typical EMDR bilateral during recurring distressing memories. Slow wave sleep appears to have a key role in memory consolidation, so that would make some sense, and in the reorganization of distant functional networks. So integration taking place, neurological integration taking place in slow wave sleep. Slow wave sleep is thought to be the sleep cycle where experience is multiply integrated into memory and mental schema. Slide 50. Let's see. Having a little bit of a brain freeze here about AIP. When negative experiences overwhelm the information processing, adaptive information processing is what AIP is. When negative experience overwhelms information processing of the brain, we are unable to process the experience to resolution, and the memory is maladaptively encoded. Inherent in the EMDR model is this kind of self-writing idea, which is also part of Diana Foch's AEDP model. It's also part of a dynamic living system model moving towards complexity. I believe it's probably part of Steve's organismic intelligence model. So all of our models seem to rely on the inherent processes and the inherent ability of human beings to figure a way through difficult experiences. Slide 51. During normal events, our brain stores memories smoothly. It also networks them so that they connect to other things you remember. During disturbing or upsetting events, that networking doesn't happen correctly and the brain can go offline, especially the upper brain. And there's a disconnection between what you experience, feel, see, and hear, and what your brain stores in memory. Often your brain stores trauma memories in a way that doesn't allow for healthy healing. Trauma is like a wound that your brain doesn't allow to heal. Because it doesn't have a chance to heal, your brain doesn't receive the message that the danger is over. EMDR targets, with this adaptive information processing model, they target the reintegration of memory. Again, at the bottom, the last quote here on slide 51, understanding the client when the adaptive information processing model informs our understanding of client readiness to approach memory reprocessing. And again, Shapiro's taking into account now the, although it's not clear what she expects that to look like, but the developmental work that needs to take place before there's adequate presence overall and general presence and resource ability for the person to enter into the TCBT model. Slide 52. Phase one of the EMDR model: relationship building, gathering information, history taking, making determinations about what memories are going to be targeted and in which order memories will be targeted for reprocessing. Phase two is the preparation and stabilization, given psychoeducational information about the model and the mechanics of the sessions. Phase three is an assessment, involves assessing the target memory as it's currently being experienced by the client. So it's kind of a little slightly deeper dive into, where does this thought, what takes place when you go into this particular thought, and they isolate the target memories one by one. So you can take a baseline measurement of the sensory components of their experience at the onset and have a way to kind of follow and track whether you're going in the right direction or not. Target memories are stage 4 through 6 are reapproaching target memories and associated linkages to other memories through reprocessing. Bilateral stimulation is used to activate the client's inherent information process system for 20 to 30 seconds at a time, with a brief check-in to ensure that the process is moving. So some kind of careful back and forth between the intervention, the bilateral eye movement, the rendering of the experience and the memory, and a careful tracking of all of that. I'm sure this is a best case scenario as far as how people practice this method. Byproducts of reprocessing are insights, shifts in the client's emotional response, a new, more adaptive understanding of what happened in the past, and the assignment of meaning to the experience, the ability to assign meaning to the experience and to understand the mechanisms by which the symptoms evolved. Phase 7 is closure. It's designed to close down any session, especially a reprocessing session, tie it up and put it away. Follow-up is used to follow up on every session. It takes place in the subsequent session when the therapist is asking for feedback on their experience, subsequent experience. So, and a evaluating of the target memory that's under consideration in the model at any time. Next slide, 53. Clinical interventions in EMDR therapy are used to facilitate processing if the client is blocked in processing, or if the therapist wants to add tracks of information to optimize treatment effects. So they can break down experiences and reprocess and interrogate different aspects of the experience. Many clinical situations where there's a reduction in distress but limited resolution due to missing information and/or the therapist's skill set, or there's limited resolution because there's a need for developmental repair of some kind. Okay. Slide 54. EMDR seems to be a model that's particularly good at integrating aspects of other models that have a sound research basis. As I mentioned before, for example, the developmental considerations and the training now that they offer, and the emphasis on essential relational components. We all know that all therapies and psychological interventions rely heavily on the quality of relationship to succeed. Okay, slide 55. A little lip service here, psychoanalytic, psychodynamic work. Psychoanalytic work stays true, as it likes to its model, and it treats trauma by looking at the impact on the capacity for representation, the capacity for self-regulation, capacity for relationship and the presence of dissociative processes. The focus is on, quote, helping patients to symbolize traumatic experiences, affects, and other mental states, and helping clients regulate physiology and affects through nonverbal, affect regulating interactions, and through the use of medication. So I think Bill Cornell is a colleague of mine who's deep in psychoanalytic ideas, but he's a body psychotherapist, and he's written some papers on how to regulate physiology in the course of analytic training, analytic treatment. Some interesting ideas. Slide 56. Psychoanalysis places PTSD, I'm sure very proudly, they place PTSD symptoms within the conceptual model, where psychological defenses, ordinary psychological defenses like dissociation, are seen as unremarkable and a common feature of psychic life. I believe they feel, as a result of this, they feel some kind of expertise over the dissociative aspects of symptomology. Distortions of time is also seen as a common feature of the unconscious within the analytic model. As you see here in the last quote here, in the basis of conceptual reasoning, the existence of actual neurosis structures prior to traumatic event is put forth as a precondition for development of PTSD. So I sense they're saying you can't succumb to a PTSD unless you've already developed, gone through the mechanisms and defenses of an actual neurotic structure. Interesting idea. Somewhat interesting. Okay, 57, psychedelic trauma treatment. Despite unanswered questions regarding efficacy, psychedelic drugs have seen a renaissance in research on their therapeutic potential, ranging from treatment of depression with substance use disorders and PTSD. Some of the dialogue and some of the chatter in this research area points to the lack of advances in psychotherapy for some of the hard nut aspects of our work with clients, and the psychedelics is being introduced as a kind of a workaround. MDMA, ketamine, cannabis, needs an A in there, psilocybin and LSD are all share the capacity for inducing an altered or opening of the sense of self. Slide 8. MDMA increases the release of serotonin, dopamine. Serves as a catalyst to psychotherapy, increases fear extinction, reduces amygdala activity, reduces fear response and shame, increases openness and interpersonal trust, emotional empathy, etc. And some of the evidence of the research RCTs is up in there. MDMA. Moving on to other psychedelics. Slide 59, ketamine as a therapeutic rationale and evidence-based. Rapid but temporary symptom reduction. NMDA receptor antagonist NMDA seems to be a kind of a chaos creating openness in the neural system that creates flooding. At least that's what I could make out of the literature. And so this is an antagonist. Ketamine slows down that fire in the brain. Okay. So they say classic psychedelics, psilocybin and LSD. Reduce amygdala reactivity. insight and introspection, new ways of seeing things, ability to be braver at looking at things. Existential distress. No research has been published. These are still restricted drugs. Using evidence from studies and other areas indicate high effect sizes. Other indications are for depression, substance abuse, end of life, anxiety, and OCD. And surprisingly, cannabinoids are included in psychedelic-assisted PTSD. I was surprised anyway. Symptom management, insomnia, nightmares, catalyst for psychotherapy, increased fear extinction, and decreased fear extinction with chronic use. Does not look that promising, but that's the report on that. Okay, slide 62. Some of the features of trauma models that seem to be cross-modality to some degree or another. Important emphasis on training, thorough training, and deep training, and capacity to move along with the client, follow and track the client, problem solve when things get stuck. Establish a safety relationship, importance on explaining the process and making it transparent, and sticking with that explanation. They all seem to have a regulatory intent, just whether you're changing thoughts and changing the way you're thinking in order to change the way you feel and then the way you behave, or whether you're changing the way you experience things sensorially. Titration is used in some models, certainly strong pool in SE, and there's the better explained exposure therapy models seem to have a regard for starting targeting memories and manageable pieces. Human to human contact, real feeling of trust, and there's your well-being is being held in the mind and heart of your therapist. More than I've seen before. There's more sensory experience included, emotional experience. We can get into that a little discussion, and imaginal experience. Here and now, which is important in somatic experiencing, is used as here and now in virtual reality, meaning that you're kind of in your virtual reality helmet with your gun in your hand, and the efficacy of the model is based on that kind of here and now experience and the working through of the response that you have. Thoughts and arousal level. Coherent narrative is the outcome, and most of these models is the desired outcome. And so each model seems to take some care at the end of each session and periodically throughout the process to draw out the story of what's unfolding and what's changing in the life of the client, and what caused the original symptomology. And then once again, the developmental considerations are increasingly a feature of a number of these models. So, okay, that's slide 62 of 62 slides in about 1 hour. So I think we want to change screens here so we can see each other and have a discussion as long as we need. Is that right? Anybody out there?
Thank you.
Thank you so much, Mark.
Okay, I'm going to get the right screen on here. Hello. There's some faces. Hi, everybody.
So, Mark, do you want us to to just unmute if we have questions?
Yeah, I was hoping we'd entertain any questions altogether. I can add anything that I remember or haven't put on the slides, but sure, unmute.
And thank you, Stephanie says she has to go. And yes, we hope to send out the slides.
Okay, we'll send out the slides and a bibliography. And every citation that I have here is available through Google Scholar as a PDF. I only chose those which we could all access. So
Thank you.
you can get the original text for each one of these citations.
Thank you, Mark. Thank you, everyone.
Thanks.
Yeah.
Great to be with you, Stephanie. Thanks for coming.
Thoughts, responses, questions, anything new?
It was so rich, so much detail presented in such a short time.
Yeah,
Getting questions and they got
Zoom.
past me. Yeah. But I was thinking a lot about, or wondering a lot about, like how each model sees person as part of system rather than individual biology or individual pathology. I mean, we're seeing more and more of that movement towards, psychotherapy has to shed this one-to-one model to some extent and look at people in their contexts.
You mean cultural and class and
all of it. Like
yeah.
we're not individual biologies. We're connected at a biological level to other people, and these traumas that happen are often collective.
Yeah.
More and more so.
How do you think that SE is? How do you think SE is doing in that area?
That's a good question.
Does it depend on the trainer?
I trained in it a long time ago, so maybe Mike knows more.
Seems to be a part of the training, and it's a big part of the literature, right? Cultural and social and economic context. If that's the kind of thing you mean.
Isn't an SE that we're holding both the systematic going and the personal, that we're actually going back and forth between those?
Ideally.
Yeah.
Ideally, being able to hold that. That's the whole thing. Yeah. Can we hold all that?
It's very, I mean, I've had a couple of different core trainers over the 3 years, and I'd say they were quite different in the way in which they picked up on that particular aspect. So a lot of the training seemed to emphasize individual treatment. The literature seems to be reflecting the awareness of cultural context now.
I was thinking about how powerful it was when I went to Esalen, when Peter used to do his 5 or 6 day workshop or whatever, and the group was part of the support. I mean, that's true in the trainings too, but I think because the trainings are didactic and Peter's thing at Esalen was, just more healing, that the audience, or whatever you want to call it, the collective was, he would bring in the collective as part of the healing. I mean, I was there when he worked with Ray, and that was very much, part of what he did. And then I just thinking, I'm reflecting on my own experience of being in the training and how powerful the demos were for my own healing, because there was always an element in the demo that I could, connect to, because they would bring up archetypal or, what have you. And so that was a big part of the process. And I don't know, there might be in the literature talk about that, but I don't know, how much talk there is about the practitioner participation in that.
Yeah,
that makes sense.
Well, the establishment of a safe relationship, certainly part of that, the presence of other safe people in someone's life, or the inability to create, the inability to create secure attachments, or the failure to have done that might be a very big obstacle in successful trauma treatment, I would think.
Well, maybe this is where that's coming from, like the bodywork side, where Kathy Kane is talking about the matrix and how do we build a matrix of support, both practitioner, both patient or client, and for the collective, of what are we tapping into when we're in the work itself.
Yeah.
And how do we do that within the models that you're talking about? How would that be spread out to be able to think about those different matrices that can be developed?
Yeah, and then what kind of training do we need in matrix consideration? I mean, what is a matrix, and do we agree on what the matrix is that we're living in? And
because you think of my patriarchy, because if that is going to be the support of my matrix, we have to look at that too, of how are we? That's a good point. Of what are we building it on?
Yeah, that's it's a big job, right? I think the more we find out about the complexity of our embodied situation, the more we see that we really have to have a huge picture of the human being in in context and in their bodies and in relationship, and it requires a lot of it's continuous training, which I think most of us have are committed to, and a lot of people are committed to it, but it's the model it's mushrooming what we need to know.
Well,
I may not specialize in psychedelics because I just can't do another.
Right.
Yeah. It can be just as simple though as the matrix of all the other people who have healed from this, to the complexity of the bigger pieces of like, how do I bring, like, I have a matrix of healers who are
Nice.
Who are my healers that have helped me. Who do I?
That's that's like a Dick only intervention. That's really nice. I like that.
Is that? I don't know. Yeah, Dick, I've heard that.
Yeah,
name.
it's just all the ancestors and all the people who have been healed, who are behind us and with us as we go through these processes.
And that to me is more of a personal thing. Go ahead, Lisa. You're saying?
I'm trying to move I did SE and EMDR sort of around the same time. It took me a few years to finish my SE. And I did EMDR in the meantime because that was readily available where I live here.
Mm-hmm.
And I've sort of tried to incorporate the two as probably these past 5 to 10 years. And I have really wanted to move towards doing group work. And so just to touch on that, recently I came upon, again, a Manitoba woman. I think her name is Heather Platt, holding space. So this is something that I'm trying to develop, with doing some group work. Dancing mindfulness is sort of related to EMDR. It's a group dance modality that I'm trained in.
Nice.
I'm just, and then this Heather Platt's holding space at the beginning saying, let's all approach this group wherever we are today, even if it could be online, thinking of creating a group nervous system container. That's my way my mind is going. Also, I just want to touch on the flash approaches. Originally, Phil Mansfield, he branched out from EMDR. Instead of focusing mainly having the model aimed around the exposure to the negative, is very, very much focusing more on the, in SE terms, the counter vortex or healing vortex, so that you just touch ever so lightly on a sliver and then back to the positive engaging focus. And then Thomas Zimmerman is now working on group. His version of Flash is called 4 Blinks. I don't know if you've heard of that, but Thomas Zimmerman's training a lot of therapists. Even tonight, he's doing a special free training. I could send you the link even for people who want to help people in Israel. And he's moving towards doing it as a group modality. So I just thought to mention those.
Those are two modalities, Flash and four Blinks. So great.
They're related to EMDR. Yeah.
Because now what I'm also hearing here, Mark, is like these other modalities that are outside the therapeutic standard of doing, I mean, EMDR, I guess, is, but also like dance modalities, body work, and where do those intersect to be able to bring in the healing that's needed for that client? And
Yeah.
it's just an interesting piece to
Well,
me.
Bruce Perry's model goes right into that. There's a lot of touch interventions and massage in adults and back rubbing. And as you saw on that one chart of the parent intervention, an advanced parent intervention after the child will allow touch when it's, coming down, reducing arousal, then the child accepted touch. And then that brought the activation further down. And that's, I think that's listed in diencephalon. It's obviously a limbic relational intervention as well, but yeah.
Well, I'm gonna want to go back and look at the slides too, just for my sake of referring out, because I come from a bodywork background.
Exactly, that's
When-
great.
When
Great.
do I also use those to be able to go, hey, maybe
Exactly.
you should try an EMDR guy, or maybe you should try it.
Yeah.
Yeah.
Yeah, no, I went into therapy with an EMDR person and I took my client and I sat in the room for a bunch of sessions while EMDR went on. Really good, really a great learning experience, and we carried on the gains that she made there and that with that client, with that therapist. We had that as a resource now. These techniques that were working, we had new distancing resources that allowed processing to continue. So it was great.
So in there, we're
I was
learning
trained in
the complexity of getting to know other practitioners and what they do, because I get a little afraid of the titration, because that's more my model, and to go into sit with someone else who does not do that, I'd have to regulate my own nervous system.
That's right.
But also just see what the progress they make with that. I don't know.
That's right.
It's a both and kind of thing. Yeah.
That's right. Yeah.
Right, but
What about
I
the
also-
question? Okay, go ahead. Maureen.
Well, I was just thinking about you being there with your client in that field with them. For me, I can just imagine as a client, like how that would really help me integrate the learning and hold my titration that I've learned through you as well.
Yeah, I made it safe. My presence made it safe for the client too. And
Yeah.
we talked about it. Obviously, we talked about it beforehand and we had an idea what we were after. Talked about it with the other therapist.
Because that's one thing that's not, I don't feel talked about enough in a lot of these modalities, is the hierarchy piece. Because you have authority as a practitioner, as a therapist, but you going in as the therapist actually adds that parental hierarchy that also is not often talked about. Yeah, just to bring that up as a thought, it's just an interesting thing to consider.
Yeah, if you're looking from a family therapy perspective, that would definitely be adding in kind of having this container that's outside the container that the person no longer has to hold everything. There's someone safe watching the ship, making sure things are kind of cared for, which then allows a deeper level of presence and settling. I really love what you said there.
For the family members. More holding for the family members.
Yeah, and you kind of functioned like in a certain way this external regulator for the EMDR and presence, and like a good kind of like executive subsystem in family therapy. You let yourself grow and learn along with providing the container, because don't come in perfect, but they're in this growth relationship with the person the same way we're in growth relationships with child.
Yeah, and we're growing as well, and it's a privilege to be in that in this work, as you all know. What do you think about this question of the emergent emotional expressions? They seem, I think when I was first introduced to CBT ideas, it seemed as though it was all about what Michael was mimicking earlier, like just change your thoughts, just change the way you think, and that affect was an emotion was not in the picture, except as a targeted behavior, right? That needed to get over it, in some way. And SE, I think there's not necessarily, there's some discussion that goes on. What you got there?
It's the emotional sensation wheel that I put on a pillow.
Nice. Wow.
I mean, we talk about the complexities. I hope I'm not interrupting what you're saying here, but
No, that's good. I'm
Is it
finding
just like-
myself on there. I think it's relieved that the talk is over. I think that's on there somewhere. Right? More reanimated, right? Reanimated.
Mhm. And is that where, where we are getting complexity as a human species, hopefully the complexity of our emotions and our acceptance of these will start to come to play too, and that we can find, I think that's where SE comes in, is the titration model, is it just isn't here, and it isn't here. We get to come out to this bigger piece to really titrate what the really feeling is, as opposed to just the simple one. So that would be my call to those other people who do these other modalities, is how do you bring in these other complex and more nuanced feelings of affect and emotion?
Is it like using learning a language while you're sleeping? Do you learn something with using a pillow? Is that
That's right.
Sleep on it.
Oh, I'm scared.
work?
Oh, I'm happy. Oh, yeah.
You know, Roger Selvin has an implied critique of SE around this, that we over titrate and don't allow the depth of emotional experience. Now, to the point of loss of control of involuntariness, which is the Reichian and neo-Reichian model, that's what's important, is the involuntary expression of the held back emotion, and that's Diana Foch's model too, is that emotions expressed to completion in the presence of a helping other is the change model, that emotion is the change agent. And what do we think about that? Is that built into SE, or is it?
I think SC talks about in cultivating or making safe the involuntary. In fact, that's something that you're seeking to make safe for the person, because especially in our culture, people are very hesitant to shake or allow. I'll just allow,
Yeah.
right? Just have allowance, and I think SC definitely, that's something that SC taught me.
Yeah, and shaking's a really important part of our work, and something that usually often follows it is the loss of emotional suppression, and the emergence of emotions, and anyway, I just wonder what you're all thinking about it. So we're all kind of inside the system here. We're well experienced. What do we?
I mean, I think SE, as it's mostly taught, SE as it's mostly perceived, is, can you titrate affect small enough that people can metabolize it, move through, and then magically not have bad affect?
Yeah.
I don't think that's the SE model. I think the SE model is, can you learn to be with the shift in pendulation? And if you're taught pendulation is, I'm going to shift someone from negative to positive and then tack them down there, that becomes that kind of problematic thing. But if you allow yourself to know that you're the psyche that allows that experience is present all the way through and is present all the way through, then what starts to happen is that there's this kind of deepening of capacity. So a wider range of authentic expression of emotion, which can include authentic, difficult emotion expressions.
Yeah.
And you're thinking of the window of tolerance. With you're doing this, you're now thinking of the window of tolerance in which you're able to allow that to happen.
Exactly. And then at some point,
Right.
Energy,
That's important.
where you just really have this bigger well of human capacity. And
does something get done that doesn't get done without the deeper well? I still have I was trained in that Reichian model a long time ago, and it's been I've adapted it since then, but just wondering.
I missed that question, Mark. What did you mean by that?
Oh, well, but the deep, does something is there something that only gets done in the deeper well, that might not get done in that more titrated in and out, so really grief, deep sobbing of every, so water's coming out of every orifice, has been
If you don't lose observer, in that process.
As long as you're embodied, that's what you're building, is the ability to embody. But at any level that someone is able to be embodied with what's happening, then there's the learning.
That's a very good point. learning.
And as a practitioner, I feel the quality of that. That to me is recognizing when, and I have to notice that in my own nervous system, when am I tapping it down because I can't tolerate it? Or when am I actually facilitating a deeper feeling of the crying your eyes out, but that they can really be there and experience it.
I would even take that a step further and say, like, radically, I think included in self-regulation is the writing response after you become fully dysregulated, lose contact with self, like get fully overwhelmed and dissociated. Do you have that capacity to be in that place, trust that movement, trust your pathway back? Because those kinds of bigger states of dysregulation can happen in life. Like if I were plopped into a war zone right now, I'm sure I would hit those big wells. Do I have enough trust in my ability to move through those big wells that I know back out,
Yeah. Well, natural healing probably goes through that, as the literature that I researched said, most people have symptoms, like deep symptoms, who are exposed to, significant trauma and recover, a certain portion of people recover. They seem to speculate that it's quite common to recover from trauma, and some not trauma that was had involuntary symptomology connected to it, not just a story about what happened, but like you really went away, you really got hit, and then you worked your way out of it. It's
one of the phrases I think about in that I chew on is, if you look after a traumatic event, somewhere between 80 and 90% of people have some level of symptoms in the immediate aftermath, but only 6% a year later have PTSD.
Right.
So I think
that's it. That's the literature.
Yeah, PTSD is only one kind of way the trauma manifests. So there's other ways it can impact that's not.
Right.
But at the same time, that never gets up to 100%. So people are obviously doing something, and I'm afraid of doing something, not that somebody has innate grit, because I think that's oftentimes used as a way to pathologize. But yeah, this is a powerful conversation, Mark. Appreciate it.
I don't think any traumatic experience is ever completely extinguished, and with would completely neutralize. That would be a crazy idea, I think. Anyway, thank you all for showing up for me. I appreciate it very much.
Wonderful.
Thank you so much for
Yeah.
tolerating.
All right. Enjoy the rest of your Sunday. I'm going to.
Yeah.
Thanks again.
Anything else we need to
Thanks
say,
for
Michael?
coming, Lisa.
Yeah, I just want to say thank you, everybody. Welcome. I'm grateful for Mark's energy, expertise. I know Mark, enjoy the freedom energy, and I hope you get to play on the beach or something wonderful down there.
Who's up next, and who's lined up here?
And I believe who is next is going to be Charlize, and she's going to be talking about exposure therapy from an SE lens. So
Ooh.
Ooh.
Great. This was a good prep then. That's
Too bad
good.
she wasn't here. Huh?
Yeah.
And when is that going to be?
I don't know the date offhand.
November, December, January, somewhere. Right.
November.
November.
Great. Okay.
We're going to be posting this on the web. Grateful for everybody's time. And just remember that Northern California Somatic Experiencing Professional Association is here to help grow the profession in the Northern California region and help get SEPs back. The more SEPs we have at the table, the more we're able to grab together, work together, and really grow this profession, supporting one another. So grateful for your all's energy and your time and your care.
NorCalCPA.
Thank you, Michael. Yeah.
NorCalCPA.com. Yeah, and we're hoping to have more of a live interactions.
Come to our community connects as well. We have so much. Thanks, everybody.
Thanks.
you.
And so I'm glad we're doing the ritual. And also, I just want to say, Linda, I am just touched beyond words, grateful for it. I feel deepened as a person for what you're doing, and also challenged in ways to become a better clinician and to grow. And I think in many ways, this workshop series grew out of a gift and a donation from Mark Schuler, who is an incredibly powerful body worker.
Right.
Okay, I no longer can officially make it through this without tearing up, but you know, here I am. And before he passed, one of the things he wanted to do was to give people who have this power to touch people's hearts with this ability to be connected, a way to share and deepen each other. And so it feels like a gift to have you be our inaugural person, because I feel like it touches so deeply the idea that Mark had set up for this thing to be here. So thank you for that. And also I want to highlight the fact that Linda is an incredibly powerful person, and we all are in our different ways. And I'm really grateful that the Bay Area is now going to start centering our leaders, our gifts, so that we can grow from each other and share it. And this feels like a great invitation to the power of community that can happen through sharing our gifts with one another. Anybody else want to say a few closing words before we just wrap up?
I want to say one thing. Sean Wilder was my supervisor, and what she said to me, I've carried in my heart. I'll pass on to you. She's, Linda, if you're going to work with big trauma, you have to have big fun. That is sage advice.
Yeah.
So,
All right. And so here we are in this containment, and you know, the world is full of all of this, you know, both sides of the pendulum. So let's have big enough fun that we can hold the heaviness of the trauma in ways that it creates a resource that matches and integrates it. And I feel really blessed and grateful to get to be with y'all in this community, and wish you all well in your next endeavors, and be on the lookout for the community workshop series. I'll send links in the chat to folks. Challenge you to connect with the faithful fools and in some way or another, and be on the lookout for our next workshop series. Oh, the link to the video will be sent out to the group here too, as well as shared in our circle.
Yeah. And keep telling your friends and colleagues to come on in and check it out. Thanks.
all right.
Yay.
Adiós.
Bye.